Okay. Good morning. Assalamualaikum warahmatullahi wabarakatuh. And it gives me very great pleasure to have two of our pediatricians here today to present to you all great topics. And I introduce to you our first speaker. Our first speaker is Associate Professor Dr. Karmila Bakar, who is one of the few pediatric nephrologists in the country. And there are not that many pediatric nephrologists in Malaysia. And we are very happy that she has been trained in this specialty. And inshallah will help will help to spearhead our pediatric nephrology unit here in PPUM. In the University of Malaya, she's the only pediatric nephrologist, and hopefully we'll be able to train many more. And she's here to share with us a congenital problem that is usually extremely difficult to handle, which is congenital nephrotic syndrome. So without further ado, I'd like to call upon Prof. Kamila to share with us her presentation. Thank you.
Okay, Assalamualaikum and good morning. My name is Karmila. I would like to present a case, and the title of my presentation is A Stitch in Time Saves 9, Treating Congenital Nephrotic Syndrome in a Resource-Limited Circumstance. I've got a 3-week-old Indonesian baby girl presented with sepsis-like illness. She was less active and had reduced oral intake. She was born full-term at 38 weeks with birth weight of 2.5 kilo in a private maternity center. Antenatally, her in utero growth parameters were normal. Her parents were non-consanguineous with no family history of concern. This is the 2-generation family tree. She's the youngest of 2 siblings. Her elder sister is 4 and she's well. The parents are in their 30s and they have got no family history of antenatal or neonatal death, and family history of end-stage kidney disease. Mom was married before and she has 2 healthy sons. At presentation, the patient was quite ill. The baby was low. She required intubation and also inotropic support. The weight actually reduced from 2.5 to 2.2 kilo. She had no dysmorphic features. Her anterior fontanelle was sunken with dry mucous membrane. The respiratory and abdominal examinations were unremarkable. She has normal female genitalia. This is the initial investigations. She had low sodium and potassium. The creatinine was elevated. She had severe hypoalbuminemia. Albumin level was only 8. She had severe metabolic acidosis as well. pH of 7.01, bicarb of 7.8, and a base excess of -26. Part of the septic workup include urine analysis, and the urine protein was 4+. Subsequent urine protein quantification came back as a UPCI of 10,000 milligram per millimole. Although the patient was not edematous, she had severe hypoalbuminemia and also nephrotic range proteinuria. So we made the diagnosis of congenital nephrotic syndrome. She was screened for congenital infections, including TORCH, which came back as negative. Her karyotype was 46XX. The genetic testing for congenital nephrotic syndrome was not done because it is quite costly. Soon after admission, she had progressive generalized body swelling accentuated by crystalloid use during the initial fluid resuscitation. She had to be given albumin infusion twice a day with continuous furosemide infusion. Unfortunately, she developed catheter-related bloodstream infection where we actually isolate ESBL Klebsiella pneumonia. So off the CVL, we tried our best to give everything oral. So we adopt a combination of furosemide and amiloride to control the anasaka. She responded well. Upon normalization of her serum creatinine, both RAS blockade and also NSAIDs were started. These strategies actually allowed sustainable weaning measures of albumin infusion with no resurgence of edema. Her caloric intake was optimized to 130 kilocal per kilo per day by increment of the feeding volume. The albumin level remained stable in the range between 14 to 16. As expected, she required thyroxine because of the loss of thyroglobulin and other mineral supplements. So the management protocol actually allowed alleviation of fluid restriction and created room for optimization of nutritional intake. And we were quite happy because it was not necessary for us to maintain the venous access constantly. She was discharged after 4 weeks of hospital stay, and she was managed on outpatient basis without compromising her health. During clinic visits, she showed satisfactory weight gain as well as a neurodevelopmental milestone. So what is congenital nephrotic syndrome? It is a rare form of nephrotic syndrome. The incidence is about 0.5 to 100,000 population. Infants with congenital nephrotic syndrome typically present with heavy proteinuria, hypoalbuminemia, and edema before the age of 3 months. The degree of proteinuria, however, varies amongst individuals, and the clinical signs may not be apparent during the first week of life. The true magnitude of proteinuria may be detectable only after correction of hypoalbuminemia by albumin infusion. These are the etiologies of congenital nephrotic syndrome. It could be genetic, some associated syndromes, it could be idiopathic, or linked to infection. For genetic, the commonest cause is a mutation at the NPHS1 gene. So NPHS1 produces protein, nephrin protein. Nephrin is important. It acts as the protein complex which link the food processes. Less common is NPHS2 gene, so it will produce podosine. Podosine is a filtration slip at the food process. Another mutation is WT1 gene mutation. Usually children with WT1 gene mutation, they have pseudo-hermaphroditism, so we need to examine the external genitalia and also do the karyotyping. Infection is more common in this part of the world. Examples of infections are congenital syphilis, congenital CMV, and congenital toxoplasmosis. So outpatient, at presentation, generalized body swelling was not really apparent, although she has heavy proteinuria and severe hypoalbuminemia. However, the persistent lab markers coupled with progressive edema in the first 3 months of life conquered the diagnosis of CNS. The severity of nephrosis in our patient contributed to the acute kidney injury at presentation. So how do we manage congenital nephrotic syndrome in the past? They would require recurrent admission for edema. So we need to give them intravenous albumin, and most of them require CVL insertion, and this CVL actually complicated with thrombosis and infection. If we are lucky, we can reach the minimum weight for transplant. It used to be 20 kilo, but now it is 17 kilos, and most patients usually did not last. What about in developed countries? Bilateral nephrectomy is performed, followed by dialysis, and after that, kidney transplant. In Scandinavian countries, where congenital nephrotic syndrome is quite common, they would do transplant when the child is about 5 kilo, and in the UK, they would do transplant when the child is about 8 kilo. So recently, in 2021, there is a consensus statement on management of congenital nephrotic syndrome by the ESPN working group. They actually suggest that infants with CNS need to be treated individually. They don't recommend immunotherapy such as corticosteroids to induce remission. Patients who has a congenital nephrotic syndrome, they should have infectious screening and also genetic testing. The initial management would include avoiding unnecessary fluid and salt intake, optimization of nutrition, and further management, it depends on the intravascular volume status and the severity of edema. Follow-up need to be multidisciplinary, and we need to refer the patient early to the transplant unit. So what about recommendation for the diuretic use in congenital nephrotic syndrome? Usually, it is quite common for us to give albumin and furosemide in patients with nephrotic syndrome. However, if a patient require potassium sparing diuretic, they actually recommend epithelial sodium channel or ENaC inhibitors such as amiloride. The reason being that the protein-rich urine from this patient actually contains plasmin that would activate the epithelial sodium channel. This upregulation of this channel will cause sodium retention and subsequent edema formation. Most of the patients, they have massive loss of albumin. So they actually suggest antiproteinuric therapy. Examples are RAS blockade. And if, let's say, the patient did not respond to RAS blockade, they actually recommend the use of prostaglandin inhibitors such as indomethacin. How does it help? RAS blockade and NSAID, it produces a better sustained levels of albumin by modifying the intraglomerular pressure, decreasing the glomerular filtration, hence controlling the amount of protein leak. Frequent need for albumin infusion and long inpatient stay will cause huge financial burden for the family. Our existing healthcare system does not provide funded healthcare to the immigrants. The high medical costs incurred would cause a significant financial burden to the family, and we could have lost this child from continuation of medical care. So what about nephrectomies? Routine early nephrectomies is no longer recommended. They actually suggest unilateral or bilateral nephrectomy in patients with failure to thrive, thrombosis, and those who had difficulty in maintaining the intravascular volume status. However, they actually recommend bilateral nephrectomies before kidney transplant in patients with WT1 mutation. So there is a significant evolution of treatment in congenital nephrotic syndrome. In 1960s to 1970s, most of the patients were only given nutritional support. No one actually received albumin infusion. The mortality rate was quite high due to infection, thrombosis, and hemodynamic collapse. In 1970s, kidney transplant was introduced. In 1980s, this disease is no longer considered lethal, and they actually gave the patients intensive medical therapy followed by kidney transplant. So what are the long-term outcome of patients with congenital nephrotic syndrome? The kidney outcome, this is multi-center studies which was published in NDT in 2019, looking at 55 patients with congenital nephrotic syndrome. 39 patients reached end-stage kidney disease at median age of 11 months. Overall renal survival about 64% at the age of 1 and 45% at the age of 2. Mortality rate quite high. Children actually died at diagnosis. They have nosocomial catheter-related bloodstream infection, and some of them actually died whilst on dialysis. The non-kidney outcome, most of the patients, they have psychomotor delay due to the muscle weakness. They observe better cognitive outcome in patients with absence neurological comorbidity, those who presented at younger age, shorter disease duration, and those with better long-term kidney function. So this is our patient at the age of 12 months. Current weight is 8.4 kilo. Development appropriate for 12 months old. She's able to pull to stand, walk with help. Look at the growth chart. She's about at the third centile. The parents are not keen for a biopsy, and we are trying to get funding for the genetic testing. Her current creatinine is 15, and her albumin is 14. This was the last 2 weeks blood result. Current medication that she's on right now: antiproteinuric, captopril, indomethacin, diuretics, furosemide, amiloride, and goodies like sodium bicarb, thyroxine, magnesium phosphate, and vitamin D. In the long run, our patient will still require dialysis support and even kidney transplant. We hope that the social worker NGOs continue to help the family, as kidney replacement therapy will pose major financial constraint to the family. So in summary, managing an infant with congenital nephrotic syndrome is challenging even in the most experienced center. This is more pronounced in this region when the incidence of CNS is rare. For us, the learning curve is made even steeper when the clinical picture is complicated by issues related to access and provision of healthcare services. So we need to balance between the professional calling, humanity, and also governance. I think that's all about my thought. Thank you.
Thank you very much, Prof. Karmila. That was a very interesting insight and talk about a very rare condition. And most of the time when we hear congenital nephrotic syndrome, most of the time it's something quite legal. So we do have one question from Dr. Chong Li Ai. How's the Malaysian outcome for kidney transplant for congenital nephrotic? Maybe if I could just add one more bit of question to that, Prof. Kamila. So maybe if you could tell us what's the outcome, or provide us a little bit of an overview about kidney transplants in children in Malaysia, and the Malaysian outcome for kidney transplant for congenital nephrotic by being more specific to that condition.
I think we don't have any patients who had a kidney transplant for congenital nephrotics.
Yeah, I suspect so. How about the overall for other conditions that's in children? I mean, kidney transplant in children.
Kidney transplant in children, I think the outcome is good, just the same as adult, but our transplant rate is not that great. So that is our main problem actually. Yeah.
Yeah, I think it's not very frequently done. What's the youngest age that you're aware of, probably?
We are using the minimum weight of 17 kilos. 17.
17. Okay. Prof. Tunku Sara actually asked another question. What are the problems?
Problems with the transplant?
I think so.
The transplant rate is not good. People don't donate their kidneys. I'm not sure why. I think we need to do something. We need to, do some, maybe we need to educate our people to give their organs. Our donation rate is poor.
Yeah. I think donation rate is poor, and I'm not entirely sure about the expertise as well. What do you think about the expertise in terms of transplanting children?
The current center for pediatric transplant is Hospital Tuanku Aziza, HKL, and also Hospital Selayang. So yeah, these are where our surgeons are for children. I mean,
we've got very good, two more questions also related to kidney transplants. Yeah. By Prof. Mary, do Malaysian children get access to cadaveric?
Yes, they are, but the waiting time is so long. So we need to educate our people.
Yeah, and I think Dr. Chong asked again, how many children in Malaysia have had kidney transplant?
How many children? Those with end stage, do you mean, Dr. Chong? I have, I don't have the number. I'm really sorry, but overall transplant rate is quite poor for children in Malaysia. Yeah, we don't have any patient with who had congenital nephrotic syndrome who undergone kidney transplant in Malaysia.
We have another question from Prof. Yazid. Can you discuss, a great talk, Prof. Karmila, can you discuss on special nutrition to this group of patients?
Okay, we want the patient to have high calorie nutrition. Some of the centers actually advise for high protein intake, so they actually give the patient myotin. But we don't really advise for that. I mean, we just give the patient normal food with a high calorie intake, that's all. Of course, we have to cut down on the amount of salt, because salt actually can cause worsening of the fluid retention. We don't want that to happen. But overall, the main thing is the calorie.
So I think I don't think we have, since let me just check. Okay, one more by Dr. Nadia. Why do you think the transplant rate is lower in pediatrics compared to adults? Really interesting talk, Prof. Karmila. I think that question has been answered a little, but
why in peds? Why in peds lower
why
than adult?
Pediatrics is lower.
Because of the criteria. So pediatric patients will get organ donors from cadaveric. Let's say someone died. Less than 18 years old, it will go into pediatric pool. More than 18 years old will go to adult pool. So usually parents, they don't give. So that is a bit difficult, I think. So we need to educate our community that transplant actually helps. It helps people.
Yeah, I mean, I think that's a great message, Prof. Kamila. I think I know this is not related. The talk on congenital nephrotic syndrome has sparked an interest regarding renal transplant in children. I think Prof. Shireen also asked about what about living donors for children, as we are doing it for liver transplant. When it comes to living donors for children, I think basically, whether the size is an issue.
Parents are usually the donors. Cadaveric transplant usually takes quite a while to be done. Size is not really a problem. As what I've mentioned just now, in Scandinavian countries, they can do when the child has reached 5 kilo, and in the UK, top centers in the UK like in Gosh, they actually do when the child is about 8 kilo. So maybe one day Malaysia can do something like that though, inshallah.
Yeah, I certainly hope so. So a great message to everybody. Those who have not signed up to be organ donors, please do so, I would say. And I'd like to move on to our next speaker. We've got a second speaker today, also from the Department of Paediatrics. For that, I'd like to thank Prof. Karmila, and in our usual way, thank you so much for a great talk and a great insight about congenital nephrotic syndrome.